Okay, so hello everybody, and thank you very much for joining us this evening for our after hours webinar on climate action, reducing emissions in clinical practice. My name's Kate Wiley, and it's my pleasure to facilitate this webinar this evening, where we'll hear from Roger Harris from Coda. Hi Roger, how are you?
Yeah, good evening everyone.
I'll introduce you properly in a minute, but first I'll just acknowledge country. So the nation we call Australia is stolen land. First Nations people have never ceded their sovereignty of their land, and respect is owed to all Aboriginal and Torres Strait Island nations and First Nations people. I'm calling today from Ghana Yurta, otherwise known as Adelaide, and hello to a group of people in Ghana is Namani. So Namani to you all, and thank you again for being here. I do think it's a sign of respect if we acknowledge the country that we're on by writing it into the chat if people would like to do this. Obviously, this is a webinar, so we can't see you, but you can see us. So I do encourage people to, if you have questions, to put them in the chat. I'll be looking at that, and at the end of Roger's presentation, we'll have a bit of time for question and answers just to, make sure we all get the most that we can out of this session. Also, for GPs joining, this is an accredited activity, but to get the points, you have to fill in the evaluation form, which I will post in the chat at the end. All right, so now it's my great pleasure to introduce you to Dr. Roger Harris, who is one of the co-founders of Coda, which I'm sure many of you are aware of. Roger is also a senior staff specialist in ICU at the Royal North Shore Hospital in Sydney and at the Sydney Adventist Hospital. And he's dual qualified in emergency medicine and intensive care. And of course, he's very passionate about climate action and the education of doctors and what we can do to make a difference for the health of Australian people and the future of our planet, which I think is a very admirable thing. And so, yeah, Roger, please, in your own time, thank you so much for being here, and, when you're ready.
Okay, well, good evening, everybody, and thanks, Kate. I guess importantly, I'm fairly new to climate advocacy, and I'll tell you a little bit of the story of how I come to be speaking to you all tonight. I guess the story begins in the early 2000s, and as Kate alluded to, throughout my critical care career, I've had a passion for medical education, and was lucky enough early in the 2000s to be working with some really interesting sort of medical education people. Mike Cadogan, Chris Nixon, Ollie Flower were a few of those people here in Australia, and we were working on a number of web-based blog posts and podcasts, one or two of which you may be familiar with. You may have heard of Life in the Fast Lane. You may have come across Intensive Care Network. We obviously were meeting Casey Parker, who was running Broom Docs as a blog post, and quite a diverse group of people who were really interested in that free open access medical education space. And so we were interestingly sort of getting plenty of engagement and tractions through those blog posts and web pages. But in the sort of middle to latter part of that first decade of 2000, the social media platforms sort of really landed on us, sometimes in a good way, as we know, sometimes in a bad way. But in that early stage, it was in a very good way for us, because it did a couple of things. It sort of really, it gave us the opportunity, first of all, to amplify everything we did on the websites, and every blog post, podcast, everything that we did, we were able to sort of promote it via the social channels. And so that really amplified and grew our audience very quickly. And I guess secondly, and more importantly, it actually gave us a return lever, I guess, for the community to speak back to us. So whereas previously people had to be on the website and maybe leave a comment or add something to a blog or to a podcast, now when we posted a podcast online and promoted it via socials, we got instant feedback and commentary, and that two-way conversation again really increased the connectedness of our community. It also did another thing. It sort of connected our community here in Australia with a whole lot of other blogging posts and podcasts around the world, and realised that there was a lot of other like-minded people interested in free and open access education and disseminating good information, having conversations. And as those connections grew, we started to think at the end of that decade that, in fact, maybe all our online stuff would be supplemented by us getting together periodically in person and sharing some of these ideas. And that's how something called SMAC was born. SMAC was an acronym. It stood for Social Media and Critical Care. And that was sort of like a conference version of what we were doing on Life in the Fast Lane and Intensive Care Network, etc. And it exploded. We rapidly had conferences for 2,000 and 3,000 people that would sell out 6 months before the event. Really, within hours of registrations opening, the event would sell out, and people would post online that it was harder to get registrations to the conference than to go to Adele, which, as a medical education person,
there's the compliment.
It was really, really fulfilling and lovely to see that energy. But it also sort of promoted something that was really unexpected to me, and that was that as that community grew and the connections and conversations within the community really brought us together, the feedback from the community, which we always lent into very intently, was telling us more and more that while they enjoyed the knowledge and skill education and found that really important, there was a whole lot of other aspects of our professional practice as healthcare providers that traditional conferences and even the SMAC conferences were only just starting to touch on. And there are things like advocacy and ethics and justice and a whole lot of things, well-being, communication. And so as we explored these sort of other areas of our professional development with the community, we were sort of seeing them be distilled, I guess, if you like, under 4 basic headings. So the first of those at the top was what we call Coda Earth, and that's why I'm here with you tonight. People were really starting to get worried. And so, mind you, this is 2018, 2019, so it's late in the game, but our community was screaming that they were worried about planetary health and the effect on their patients, and they wanted to talk about it, and they wanted to be talking about what do we do about it. They equally were worried about ethical issues, and ethical issues that really, the one that just stood out above everything else was around equity within healthcare, and gender inequity was at the top, but racism and disability equity was right up there. And it was actually all about what was happening within the healthcare profession itself and what the impact of that inequity then was on our patients. And a lot of talk around how do we fix this inequity so that we can be better providing equitable service to our patients. There was a big heading of sort of talking about communicable and non-communicable diseases. And I guess having had our origins in critical care, there was a big focus on sepsis and the global burden of sepsis, which, as many of you would know, kills 20 million people a year worldwide. And so that's a massive problem. And the final sort of pillar or domain of interest was, I was happy to say, under the educate pillar, was really around, free open access information. How do we equitably disseminate information and make sure that everybody around the world, all healthcare providers, are sharing the same information? And interestingly enough, in 2019, there was already, and this is pre-COVID, a big emphasis on disinformation and how do we battle disinformation. Of course, we've all got bloody used to that in the last 2 years. So basically, SMAC transitioned to Coda, and Coda is still administered by the same not-for-profit charitable trust that we set up some 15 years ago almost now. And that trust is DGR listed Australian, ACNC listed charity. And that administers everything that we do, so that the vast majority of people that have worked in the free open access medical education space with us have contributed all their time for free. So obviously people like myself get tremendous enjoyment out of it, but I would have contributed many, many thousands of hours over the last 15 years to this project for free, because I love it. And in fact, I even registered to go to the events when they're on, because I believe so strongly in the charity, and we're lucky enough in this country to be able to do that. But there are a few people that help us in the administration that get paid, but almost everyone is a volunteer. And Coda, I guess, as a rebirthing of SMAC, was not an acronym like SMAC. Coda is a word that some of you would be familiar of. I had to learn about it, but the creative people within our team came up and said, Coda is the musical or literary term, that sort of, I guess, reflects on the main body of work and brings it to its final conclusion. And I guess for us as medicos, we felt that we didn't want to just talk about things, but that we wanted to take action. And so Coda felt like a nice symbolic name to us. Now, I certainly don't need to talk to this group about why people were telling us that they needed to act, but we were super aware that the CO2 emissions were just continuing to increase. They, have maybe plateaued slightly with some of our period of COVID, but they've been going up and up, and we all understand the science of what's happening in the atmosphere as that CO2 levels rise. And even more poignantly, I think, for us as medicos, this was brought home to us earlier this year with the Harvard T.H. Chan School of Public Health collaborating with a whole lot of scientific bodies at various universities in Leicester and Birmingham, with geologists and physicists and climate scientists. And they came together and produced this report, which staggeringly attributed 1 in 5 deaths globally to particulate air pollution from burning fossil fuels. And I think the reason this stuck with many of us in healthcare was suddenly this put fossil fuel pollution on the same footing, the same number of deaths per year as tobacco smoking. And so I guess there was this sudden, clarity for many of us that in our advocacy for better health for our communities, we have had to fight for the last 30 or 40 years against the tobacco industry and the tobacco lobbyists. And all of a sudden, as medicos, we suddenly saw the link here that fossil fuels were very much, I guess, weaning ourselves from our fossil fuel addiction was the next big challenge for us to advocate for our communities. And finally, again, you would understand better than I do, but I've learned from people that you would know, like Forbes McGain, who's another intensivist like myself, very much about we can see how carbon intensive our healthcare is, particularly in tertiary hospitals where intensive cares are. But we all know that it contributes such a large proportion of the total emissions for our nation. So I guess based on all of those things, we felt that this was the first one of our pillars that we really wanted to start developing an action plan for. Now, mind you, our community were not people that were well versed in this sort of policy in the environment. This was, rank and file medicos that were starting to get really anxious about the climate emergency and seeing what was happening and feeling like we had no control over it. And how did we connect? So, of course, we consulted with people like Forbes McGain and Courtney Howard and Jenny Miller and people that many of you might be familiar of around the world. And they assembled for us a fairly diverse group, geographically diverse, culturally diverse, and also diverse in terms of their expertise. There was doctors, there was scientists, there was social scientists and psychologists. A whole raft of different people that started collaborating with the express brief of developing I guess, a top 10 list, if you like, of areas where healthcare needed to start taking urgent action. And within that top 10, what we were asking of them was to really identify areas where we thought that not only could we take action, but the action would be meaningful, that it would be achievable and sustainable. And then we had to sort of work out, I guess, via what I call a ladder of engagement. That's our education background coming in there. How were we going to bring this to our audience? Because I guess while many of the rank and file medicos that I work with have eco-anxiety, if you talk to them about, you know, policy stuff and the minister and this sort of things, their eyes glaze over and they think, oh shit, that's not going to go anywhere and that's not me and I don't know what to do. But they watch us just burning through carbon in our everyday life. And, you know, this generates such eco-anxiety. So we wanted to have a ladder of engagement for our community that worked on actions sort of in this framework of what we call micro, meso, and macro actions. And I'm sure it's something you guys have heard of before, but it was new to me. But it made a lot of sense. You know, micro actions were actions that people like myself could take immediately at the bedside. I just needed to understand the importance of the action and why I should be taking it and put it right up high on my agenda, but I had control over it. And whether I was a GP in my own practice or whether I worked in a big health system and an intensive care unit within a tertiary hospital, didn't matter. This was something I could change myself. The meso actions, of course, were more at that sort of local community level, either your entire practice, private practice, or, you know, within an ICU, for instance, a domain of practice. And then the macro actions is much more, I guess, what I, you know, understood organisations like CAHA and DEA and others were doing, which was really trying to, you know, tackle policy and government and make a difference in that sense. So we got our list of actions, we had our ladder of engagement, and then we just wanted a way to present it to our medical community. And we decided we'd like to do everything in threes, typical education principles again. So we had a three-stage process that people could really easily get on board and understand. So first step was a commit step, which was simply signing up to take action. And I guess, you know, the psychologists were telling us that that was an important, you know, social tipping point in the whole thing, that we really needed people to sort of, you know, not quite take an oath, because I guess, you know, we based what we did in our commit step on the planetary health oath that was you know, I guess a take on the World, you know, Federation of Medicine's new model oath. We felt for our community oath, I don't know, it wasn't the right word. I don't know, the younger people in the community think there's something, you know, weird about taking an oath. So we had to try and negotiate that, and we came up with this commit step, and I'll just show you a little bit about what that meant to us. But it was a very easy step for people to take, as was the second step, which was really an examine step, which was really only getting people to spend 30 to 60 minutes doing their own carbon calculator, and trying to just get them to take a bit of a dive into that and get a little bit of literacy in carbon in their own lives, so that they could then sort of understand why we were taking actions. And then the third step was to start looking at the actions that we, micro actions that we roll out. So if it's okay, I'll just show you this. It's only 60 seconds. Hopefully I can play it for you somehow.
Yeah, of course.
Let me try that. Maybe it's not going to play. I'm going to skip it because it's not playing. But that was a short video really that laid out much of what I've just told you in 60 seconds graphically and with a few words. And that sort of formed the basis of where people signed up. Then they did the second step, which was the carbon footprint calculator. And then we land, I guess, most of what we want to talk about tonight, which is some of these micro actions, and I'll be very interested in your feedback. I don't know if you want me to stop there for a minute, Kate. I've been talking a lot.
Oh, I just want to just acknowledge just go right back to the beginning, where I'm just very excited that you came from such a grassroots place, that you, right when you started Coda, that you were listening to, your members, your people around you, and they're saying, we want this. And then you've responded to it and created something. And I think that's, I think that's really great. And also just the GEOS Chem study, pollution at 1 in 5 deaths globally is startling, I think, for most people when they first hear it. And most people, I think often people meet that fact with disbelief, but it is such an effective way of making people realise how serious this problem is. And it's a really galvanising piece of work. Yeah, so I just would just acknowledge that. But DEA, we're very natural allies. Everything you're saying, we're absolutely agreeing with here. And I love, really find this really fascinating. So I'll let you keep going, but I'm sitting here really enjoying myself.
Perfect. Yeah, I think it's interesting. The mission of the charitable trust was really to service the community with free open access medical education, which we were constantly wanting to champion innovation in that space and increasing the translation of knowledge from the bench to the bedside. But the secondary sort of, I guess, non-educational mission, so the mission was to really innovate education and deliver it, and secondarily to build the connectedness of the community. And so I guess in doing that, from the very start, it was always about leaning in to, the feedback. Sometimes the criticism was pretty harsh, but, some of that harsh criticism was sometimes the best criticism. And so, leaning in and listening, takes you to places that you didn't really expect to go. And here we are Coda's talking about climate action. So with our first 3 actions, which we've just released in the last bit over a month now, these actions we chose because they fulfilled our criteria, and they sort of also, as you'll see as I present them, they nicely sort of dovetailed into other stuff we were already doing in the education space. So they made a lot of sense to us, and I'll explain that a bit more as we go along. So this is the first one, and in some ways the impact, if you like, I guess the carbon saving is much harder to quantify, and it's a small step, but it was again something that we felt was very much within reach, and it also dovetailed with a lot of what we'd been doing with choosing wisely and trying to look at the value of care. This practice has been published, if you're interested, in Australian Health Review. So I've just put the link in the notes. You've got the slides, Kate. I'm happy for you to disseminate them to anybody. But you can also get those links on the website, and all the evidence that underpins these things you'll be able to see on the website. So when you go on the website, I'll just go back, that was the way the web page would look. You'd be navigating to the tab up the top there, which says Coda Action, and then you'd be looking down to the actual actions within that. And this would be the first one that would come up. And as you go through that, this action on the website, it's much more interactive, but there is a PDF version that you can download and have around. So that's what the PDF version looks like. Don't try and read it, but it's a couple of pages. The idea is that the action is really, if you like, something of an abstract. And the idea is for people that are not super literate in the problem, but are worried and want to contribute, they can start here, read something that is, been simplified and is full of references and helpful links, but you can read it within 30 minutes and get a good idea of why you're doing it and how it's to be done. So it makes it sort of simple for people to get started, and then they can go back and read more and more about it. The basic pro forma for the template for every action is what is the problem that we're trying to address? What's the action that we're proposing? How do we measure it or audit what we're doing in that? Tell us any success stories that you can do. Obviously, underpin it all with all the references and resources that people might want to look at, any special lessons, and obviously who the authors are. Now, this first action, the way we do it, and it's, be important point to make, is that all the actions are being authored by 3 to 5 authors. The reason we've done that is because we choose, first of all, people who we know are going to get it done, that have the expertise and the knowledge to do it, but it will also deliver. Secondly, we want these resources to actually happen, whereas if there's 20 people working on it, as all of you will know in your experience, it's going to take 20 years to deliver it. 3, 4, 5 people with one really good leader will make that happen. But none of what we do in the template is set in stone. It's really what we want to do is get something up for discussion, something that's been underpinned with some good evidence, but then it goes out to the community for comment, for feedback, and for remodeling and additions. And I think crowdsourcing some of that feedback is really helpful, because obviously something that we come up with here in Australia is not going to be particularly applicable in an environment, a different economic environment or a different cultural environment, etc., political environment. So we obviously look and really, as you'll see at the end, really look for ways to make that interaction and crowdsourcing happen. So in the case of the unnecessary test ordering, the first question was, how are we going to deal with it? What's the action? And how do we sort of deliver resource stewardship in this space? And this is a word that we use a lot because I guess it's a familiar word to most of us. I deal with everyday antibiotic stewardship in my intensive care with the microbiologist and other aspects of stewardship. And I guess here what we're trying to say is what are we going to do about test ordering? Why is it important? And where are we going to start? And interestingly enough, as I said, this dovetailed very much with what we did with choosing wisely around test ordering anyway. So here we were just feeling like we were adding in a third level of accounting, if you like, to test ordering. So, choosing wisely was very much about looking at what you were doing and what was the value to the patient, and really trying to reduce our low value care. And secondly, it obviously identified that there was an economic cost to a lot of those tests, and that was a cost to our community, and we were responsible for that. And we need to show stewardship in how we spend the health dollar. But now, of course, we wanted to add in a carbon cost, a third layer to that accounting. So we started with the test ordering. We basically asked people to look at test ordering in your own practice. So we set out an audit for people to identify what's the most common, start with the most common test that is ordered. Have a look at it, but don't just identify what the common tests are. Ask people about why they're ordering the tests so that we can understand the culture behind it. Is it underpinned by good guidance, or is it actually just a cultural practice that we've got in the habit of doing that actually isn't good value care to the patient? Then once we understand what tests we're talking about and what the culture is, develop a specific guideline for that test ordering, when it should be done, perhaps when it doesn't need to be done, and follow that up with a really high level academic education program rolled out to the doctors, the nurses, the physios, whoever needs to be involved in it. But make sure that we just don't publish that guideline, but that we actually go around and make sure that people have seen it, that we answer questions and do the sort of academic detailing to make it really resonate within the space, and then measure it and have a look and see what happened. So I'll tell you the success story with this program just within our own intensive care, because we sort of went ahead and did it. I work in a level 3 tertiary ICU trauma center, and it has 58 beds, and we do 66,000. I couldn't believe this when I first saw this number, 66,000 arterial blood gases a year. Now, for many of you in general practice, you'd be like rolling your eyes and think, what the hell? But of course, our patients all have arterial lines in, so it's bloody easy to take blood out of them. And they get a truckload of blood gases taken. So we looked at not just how many were done, but what the culture was behind that. And interestingly, what we found was that many people were taking blood gases because they felt the need to. The nurses often felt that they couldn't hand over the patient to the next nurse without having done a blood gas recently, that there was various practices that they felt like every time they changed the concentration of oxygen on the ventilator, they should redo a blood gas, even though the SATs were 95 or something. So there was stacks of these tests getting done, and we estimated from that feedback that about 50% of the blood gases were probably unnecessary. So we then set about developing a clear guideline, and we explained to people a few things. We explained to them, firstly, that 30% of patients that spend more than 3 days in the ICU become anemic while they are in the ICU, so that we were harming patients by taking their blood all the time. And half of them end up having a transfusion of blood. So that's how much blood we were taking. We explained to them the dollar cost and the effect that was having, and that money really, we were responsible and we didn't want to waste that money. And they got it. And they also, a little bit about, with these tests, sometimes we do a test, we don't know why we're doing it. Then we find there's something like the potassium slightly low, and next thing they're getting, 20 millimoles of intravenous potassium in 100 mils. We've just given them 100 mils of fluid that they didn't need. And so, this low value care turns out to be actually harmful. And they really understood it. Believe it or not, within 6 months, the rate of arterial blood gases had decreased by 31%. Now, I'd have to tell you, we didn't, luckily we had Forbes helping us with looking at the carbon cost of that. But we estimated that because we take a little bit of blood out of the arterial line and discard that, because it's mixed with saline before we take the proper blood test, that saving, 31% decrease, saved about 100 litres of blood that patients didn't need to give. It saved $770,000 that it probably took one person to do 20,000 blood gases, one whole full-time staff member equivalent, and that there was a lot of CO2 that we could have saved in that, and did save. So that's a success story of sort of what we were able to do by following that. I don't know if you want me to stop there before I go on to the next one.
I'd love to have a little comment there. I just think that's a fabulous success story, I have to say, Roger. And it's just, you could, take that out further, to any hospital in Australia and, ask them to consider those. But obviously, you're asking everybody to consider, the tests that are in their own world, in their own department, so for, in general practice, there's so many tests that we order just sort of routinely that, why are we really ordering it? And does it really change the management of the patient? Now, that's the fundamental. Isn't that why we're meant to order investigations in the first place? Is because, it's going to change our management. And if it's not going to, does it really add any value to their care? And also, as you allude to, you might uncover something that then, you're actually, harming them in some way. And so that's obviously not great clinical practice. And then, there's the carbon. So, these are win-win-win scenarios, aren't they? Win for patient, win for the money, win for economy, and win for carbon. And, it just seems like a pretty straightforward thing to do.
Yeah.
So, I think it's great. And I think that, we as doctors across the country or health practitioners across the country need to consider this in so many of the things that we do. And, if we reduced our low value care and our harmful care, There was that excellent study recently. We'd reduce our emissions by about 50%, which is, thank you. How easy, and it's not going to, and we improve patient care and save time and money. It's easy.
Yeah, I think we chose that shift practice for the first one because it was easy to understand. Obviously, in terms of the impact, it's a smaller impact than so many other things that we could do, but we felt like it aligned with other really important messages that we were already promoting. And so it was a really good place to start. And as you say, once you sort of hopefully start on the slippery slope, you just start to see opportunities everywhere to make a start. But, when you don't make a start, you feel a bit overwhelmed initially. You think, what am I going to do? The hospital's not recycling anything, nothing's happening, and you don't know what to do. Whereas you can, start making these changes and it gets you moving. So,
thanks, Roger.
This is the second shift practice one, and this one I'm frightened about talking to any GPs in the audience and things about, because I don't prescribe these things. Obviously, I give them mostly because the GPs or respiratory physicians have prescribed them, and my patients come into the ICU on these. But obviously, this was an important choice for us for a number of reasons, but most notably, I guess something you all would be familiar with, but another staggering thing that came across for me was that between the next two things that I'm going to present, the pressurized metered dose inhalers and anaesthetic gases, they account for 10% of the carbon footprint of healthcare. They account for an enormous amount of the carbon footprint of healthcare outside of the hospital. But anaesthetic gases inside the hospital are enormously important to us. So we wanted to put these two on the agenda and flag with people, what was happening. And I was stunned to find out just what the impact was of some of these pressurized metered dose inhalers. But I guess many of you know that already. So what was the problem? The first thing for us was so important because we'd watched a little bit about what had happened with the British Thoracic Society weighing into this, and just the uproar that happened with people worrying about asthma. And I would have to say, we're acutely aware that we don't want to, suggest people, do anything other than what's right for the patient. I started my career in critical care 30 years ago, and I used to see and struggle with so many asthmatics in both the ED and the ICU, and ventilating them was a nightmare. And we've only just started to see a few asthmatics again in recent times with all the mold in Sydney, where I work, because of the rain that has been coming the last 6 months, I think. And so we're back having a few asthmatics, and it reminds me what a bugger of a disease it is, particularly when they get to me. But because of such good management out in the community, we hardly ever see them anymore. And so we're acutely aware that patient safety is paramount, and all that, patient-focused conversations have to be at the front of everything we do. But the problem is, as you know, that the pressurized metered dose inhalers contain a propellant, and the propellant is staggeringly, 1,300 to 3,300 times more greenhouse gas warming, global warming of CO2. Just can't believe it. That in the UK, where we've got good data on this, the total healthcare emissions, 4% of it comes from propellants in these devices. And that one pressurized metered dose inhaler, like the one shown on the website, is equal to driving a car 300 kilometers. So Forbes gets all this stuff for me. Blame Forbes if you don't believe it, but he's shown me the data, and it's compelling. And I must admit, I couldn't believe it when he was saying we've got to do something about these puffers. And I was like, really? Surely not. Anyway, that's how it started. And so how are we going to exercise stewardship in this area? So the first area that the program identifies is, can we reduce use? And I think We had a fantastic member of the team that really led the team on this, a fellow called Brett Montgomery. Some of you may know him. He's a GP in West Australia. He's an academic. He's very well versed in this area. He works with the Thoracic Society, Australia, New Zealand Thoracic Society as well. And the first thing he said, is that in primary care, in general practice, in respiratory clinics, we first need to make sure we got the diagnosis right, because it's amazing when you're seeing these patients, how many of them perhaps don't need that medication. More importantly, when we're reviewing these patients, we should be looking more to the preventers, which is what's made such a big impact, as I'm sure you all know. And we should be regularly reviewing people's techniques and seeing if they've got a spacer and things like that, so that we can reduce the dose. And that's all in the template. Then obviously, considering alternate treatments, the dry powder inhalers, recognizing that people with severe lung disease and poor vital capacities or young children probably can't use those things. So there are some people, and we sure as hell don't want to shame anybody who needs a propellant into thinking they don't deserve it. It's that, it's so important, and that's why we're cautious about the way we talk about this. But it's really, I think we don't need to make decisions for people. We obviously need to have patient-focused conversations, them with information as well, so they can make the choices. We don't have to paternalistically make those choices for them. And it's interesting that on our website, in the template, elsewhere, and many of you would be aware of the work done by Alex Wilkinson and others in the UK. He's a physician, respiratory physician, and he runs something called the Green Inhaler website. And there's an enormous wealth of really useful patient aids and things on that website. And that's, you can get to it, all of that, through our website. And Alex worked with Brett Montgomery on this. So they're two real experts developing this for us. Finally, recycling in terms of getting both the canisters themselves. As many of you would know, 50% of canisters, when they look at them, are still half full. And they then, so they've been wasted. Luckily, now some of the propellant devices have got metered dose counters on them, which is important, so people know when they're empty and they don't just throw them away. But if they're thrown away, those gases, of course, aren't disposed of properly, and they just leak into the atmosphere, and that's a real problem. And people need to know that the plastic shell around the canister can also be recycled in the rubbish bin. But we're encouraging pharmacists to actually take canisters back, and then for the pharma companies to develop a way of disposing of them. And finally, supporting innovation is, something that's really exciting, because a few companies, and AstraZeneca is probably one that's out in front here, does have a propellant coming, which has got 5% of the footprint of the current propellants. So it's a massive reduction for those people that do need a propellant. Some success stories on this. I mean, it was really interesting to talk to Alex Wilkinson in the UK, because he was saying there's many countries with, significantly and similar asthma rates to Britain and other areas in the EU where they just don't have metered dose inhalers. They only use dry powder. They just don't have them. Sweden and Finland, a lot of these countries, they still have airways disease, but culturally they just haven't come to rely on them. So that was just interesting in itself. In the UK, they've got some big projects underway. Alex is involved with one in Hull. They're looking at anybody who has a prescription for a pressurized metered dose inhaler that has more than 6 per year, and they really work with those. They focus on those patients, and they work on them to look at their technique, look at optimizing their treatment, and look at making sure that they're treating anything else underlying, whether it's heart failure, whether they're still smoking. I guess, as we all know, that the hardest things to do, but the ones that are going to make the best difference, is preventative care, right? What you don't want is them to come and burn carbon in my ICU.
Let's prevent them burning carbon in my general practice room, right?
Yeah, well, that's another step. you can prevent them being there, that would be good. But I really respect that. Obviously good pre-hospital care will keep them out of hospital, and that's obviously we are the worst at burning carbon. And I've alluded to what AZ's doing, but again, part of the template is a petition which is working through our PBS and TGA to just really to start making them aware of carbon accounting, because they just don't, it's not even on their radar at the moment, which is incredibly frustrating.
And there's just a little aside there, Bricanol, which is a dry powdered inhaler, short acting beta agonist, the TGA indication for that is that they have to have kind of failed Ventolin first. And so, we need to just change those wordings so that it's easy for GPs to, prescribe something with a lower carbon still effective, that sort of thing right from the beginning. Yeah.
And I guess a really important thing to mention there, that's very relevant for something like this is the different economic and cultural environments, around the world. So, Brett was very aware, I guess, that, dry powder inhalers are more expensive in a lot of low middle income countries than they're more expensive than the pressurized metered dose inhalers. So I don't know whether that's something pharma's doing. Please, I hope not. Feels a bit like something the tobacco industry would do. But it's just the sort of thing, I guess, where when we have these templates and we get feedback on the website about that, we do get some really helpful suggestions, and I'll show you that from around the world in a second. Any other comments before we move on to the piece de resistance?
Just the comment that basically well-managed asthma has less carbon emissions. Like if we do our job well, we reduce our emissions, and that's something that applies in so many cases and certainly applies in asthma.
Yeah. So this is the final one I was going to talk about tonight. This is something that we've had really tremendous reach on. We published this in the British Journal Anaesthesia a month ago. It's had over 100,000 views. It's been very, very popular with anaesthetists. And anaesthetists, interestingly enough, a variant of the critical care community who are very green-minded, and aware of this. And so the story behind the anaesthetic gases, as you may know, that they account for about 6 to 7% of the carbon footprint of healthcare and an enormous amount of the footprint of hospital carbon emissions. So the problem is that the anaesthetic gases are potent, and a couple of them, particularly desflurane, is not only expensive, but it is, many orders of magnitude worse than other drugs that, when I was training with in anaesthesia, we used things like isoflurane, halothane even, believe it or not. But now we have, the other agents as well. But desflurane is new. There's no clinical evidence that it offers better care. So it's a low value treatment, according to our guideline. And it's just stays in the atmosphere for 1,000 years. And it's terrible. And believe it or not, good old nitrous oxide is just as bad because it lasts longer in the atmosphere. And those two drugs are just dreadful. But, it's a shame for nitrous because it's a bloody good drug. Obviously we use it in all sorts of places, in pediatrics, in obstetrics, and in anesthesia. But we'll talk a little bit about that. So again, in terms of how our template works, and obviously this is all just distilled down, and you can see it in its true value if you look on the website. But the first section is really about reducing the use of gases in general, and it's just all about low flow anesthesia. And people like the lead author, Jessica Hegedus, who's from Wollongong, Forbes McGain, Jody Sherman, who's at Yale, they are experts in that area, and they've pulled it all apart, and even accounting for the increased use of the CO2 absorber. You know, when we've got low flow states, we rely on the CO2 absorber in the circuit more. And so, you know, if you're going to use up your CO2 absorber and then your scrubber, and then you have to throw that away, we have to account for that in the comparison. Still, low flow, hands down, you know, is much, much better for the environment, and no difference. And it's just a case of thinking about it and just turning your gas flows down when patients are well established on anesthesia, and there's great protocols for that. But, you know, use alternate gases, as I mentioned. Use isoflurane or something instead of desflurane if you're going to use it. One thing that, again, another jaw-dropping moment for me, is that a number of hospitals around the world who've done audits on their nitrous oxide have worked out that about half the nitrous that's prescribed half the nitrous that's procured by the hospital actually gets to the patient. Half of it leaks out in the pipes. Can you believe it? Like, I was like, what? How can that be? And so one of the case studies shows amazingly, you know, by just having nitrous in tanks, just halves the amount of nitrous your hospital's using. So just get rid of the old pipe systems that are leaking and losing it everywhere. You know, obviously some of these reporting comes from the UK, which is, I hope no one's British online. I'm sure there are probably a few, but when I worked in the UK a couple of years ago, it did feel like a third world country at times in terms of the infrastructure. The healthcare was great. The infrastructure was terrible. And I'm not surprised half the nitrous leaks out in some of those hospitals. There's good alternatives like TIVA, which is total intravenous anesthesia. And in fact, many of our trainees, anaesthetic trainees that come through intensive care, virtually have never used volatile agents. They use TIVA all the time. And again, some people try to claim that the plastic syringes and things that we use in the TIVA offset any value. That's not true. We've looked at the plastic, and anyway, we're starting to look at recycling the plastic syringes. So there, but TIVA wins hands down, and often the patients tolerate it better. And there's some good guidelines around that. Just some success stories on that. Jody Sherman, who's one of the authors on this template, who is a lead in Yale, they removed desflurane in 2013. They've saved $1.2 million because it's so expensive a year just in doing that, and an enormous amount of CO2 each year. We've got a really great group operating in Australia that I'll just give a shout out to, which is the TRASH group, which is a group of trainee anaesthetists who are doing research and audit for sustainable healthcare. And they're doing great things here, and they've got multiple projects underway in this area. And just one example that I put up for, and there's quite a lot of them on the website with nitrous, but Portland here, 2019 in the States, 958 tons of CO2 saved by stopping the piped nitrous, stopping the piped nitrous, all of that CO2 saved, and saving $120,000 American dollars a year by moving to cylinders. And that was accounting for the cylinders moving around. Mine, you know, they're pretty, when you get Forbes and people onto this, it's sort of scary because you think, oh yeah, it's just about the cylinders. And they say, yeah, but hang on, the cylinders have got to come on a truck. And, you know, obviously the nitrous does come in a truck, but this is taken into account. So yeah, amazing.
Really good accounting and auditing.
Yeah. So I'll just finish with a little bit of smack that has snuck into Coda. So, you know, being medicos, we don't take ourselves too seriously, obviously. And, but we wanted to make these sort of micro actions and the meso actions live on and get people involved and interested. And so the way to do that was to make the templates interactive. So when you can go on the codachange.org website now. You can look at everything we've just spoken about in much more detail on the website. But if you want to interact with the with the template. If you want to make a comment or leave a new idea, et cetera, you have to log on. That way we can obviously audit and make sure the crazy people don't get on there and put stuff that we don't want. But what it also gives us is the opportunity to say to people, every time you interact with an action, if you just simply share it with your friends, if you take the next step and you make a comment, if people like the comment that you've made and it gets upvoted, that has a nice spin out effect in spreading the word, but also you get rewarded smug points for those interactions. If you come up with a different idea, if you add something super valuable, then you get more points. If you do your own audit and you post that audit online, you get a stack of points. So you can earn lots and lots of points. It sort of keeps the action alive, keeps people moving with it. And we really encourage people from other countries around the world to sort of interact with that and give us their own experiences, whether that's economic, cultural, geographical, whatever the challenges that they face and how they try to get around it. You know, we're really welcoming and desperate to get that crowdsourced feedback. So there's about, I don't know, 140 or something people really active on that at the moment. Hopefully a few more of you might join in tonight and start looking at that and signing up and getting involved. And hopefully when we have our main event in October, that'll go a bit further. You can notice that I'm actually second on the board at the moment. I'm just putting that out there. I'm pretty smug. And it's funny, a few people go, oh, smug, that's, you know, is that really what you mean? And I think, you know, one of the things we've learned through our interactions online is to just, you know, last thing we want is for people to really be smug and to be trying to compete on the leaderboard and make other people feel bad. So in our tall poppy takedown, the smugger you are, the more people are going to poke fun at you. But that's how it works. I'm sorry I've spoken so much, Kate.
Oh, no, you've been great, Roger. And look, come on, who doesn't want to be a smuggle? Everyone wants to be a smuggle. They do. You know, it's just too funny. But that's been fabulous, Roger. It's been such a great hour listening to you and what your group is doing. And I think you're just achieving so much. And it's you know, it's really heartening to see. It's always, personally, always find it really gratifying to know that there's other health practitioners out there working hard to, you know, make a difference. And, you know, and when we think about our, you know, that we are a big chunk of Australia's emissions, and, you know, now we have a government that has a 43% emissions to target. You know, if we got our 7% down by 80% by 2030, that's 5% of that. You know, we're really helping, and, you know, we have a community there willing and ready to help. So, you know, go us. I do have two questions in the Q&A to answer, if that's okay with you, Roger, if you just want to if you can quickly answer them. I know we're kind of almost at time, and I am going to post the evaluation into the chat too while we do that. But the first one's from David, and it's really about engagement. So how do you try and get engagement from medical colleagues who think that doctors should stick to the medicine in front of them and not matters such as climate action and health effects of climate change? You know, have you basically the resistors, you know, what do you do with them?
So I mean, obviously, luckily in our community, because it's, you know, grown up on the online space, there's not as many laggards as there is elsewhere, you know, like what I encounter in the hospital space, I guess, outside of Coda. But I would say a few things. The first is that, you know, we are leaders in the community. Every time we survey who are the trusted members of the community, it's doctors, it's nurses, it's healthcare workers in general, certainly not politicians, right? We know that. So we are trusted, and, you know, we are very privileged to serve as medicos. And with that trust comes the responsibility to take leadership on issues that affect our patients. So I think, as we alluded to, we all know that just polluting the atmosphere continuously is going to cause problems. I mean, everyone knows that. The National Farmers Federation knows that, for goodness sakes. They're all saying that we wouldn't treat the land like that. Why would we treat the atmosphere like that? It doesn't make sense. And so, pure and simple, we've got to take leadership, because it is in our lane. We are very responsible, and the final thing I would say is that, the fourth tenet of our medical ethics is non-maleficence, and so do no harm. And
Absolutely.
we are contributing 7% of the carbon emissions through delivering healthcare, and a lot of it is reckless.
Yeah.
We have to stop it.
Oh, I completely agree. And what's the first line of the oath? I consecrate my life to the service of humanity. And if we're not addressing the greatest health problem facing the planet, we're kind of missing the point of what we're about as a profession. It's so vital. There is one more question. It's a slightly more controversial question.
Oh, good.
There's some controversy. Thank you for the presentation, says anonymous attendee. Population is a major consideration when it comes to carbon footprint. Why are we not looking at the impact of IVF and other population growth measures? And I have to say that's one of these, that's a very ethical question, and it's maybe one that's very difficult to answer. I don't know. What do you think of that?
It's 100% it's difficult to answer, because there's no question at all that population is the elephant in the room, right? We know that. It's very difficult, though, I think, for us with our privilege, in a country like Australia, to point at other countries. And in a way, other countries are right to say, you can't be telling us, how to run our populations and culturally what we should be doing. So it's such a vexed area that it's so difficult. Yeah. I would say for us, we have got to do what we can in our clinical practice, because that's who we are. We're healthcare providers. Many people have another hat, within DEA, where they're really activists and policy activists and things, which is beyond the scope of most of us. But for me, I would say I have to do what is, in front of me in my practice. I have a responsibility to act. I need to start taking action on the things that I can in healthcare. Some of those bigger issues like population, not stepping away from it because it's a massive problem. Just not sure where to start with it. And so I would bypass that question.
No, fair enough, Roger. And look, it is a really hard one. I think we'll have time for one more, but my little comment on population is the best way to reduce population growth is the education of women and girls and providing contraception. Okay, and the last question before we go is, can you envisage a day when nitrous is no longer used in healthcare and anaesthesia? Do you think that'll ever happen?
Look, I mean, so remember, I don't do any anaesthetics anymore, so that's probably a question for someone like Forbes and the guys that wrote the paper on it. But I think yes, there's just so many other alternatives for everything that we do, right? And so this is the sort of exciting thing, I guess, about starting the templates for us, is that straight away we've started doing a project in the ICU now on, we do something many of you wouldn't be familiar with, but everyone gets pneumatic calf compressors, right? Now, it's terribly low value care, because most patients in ICU are on Clexane, and there's no evidence that having compression stockings and compression devices, but they're made of plastic and they're single use and they get thrown in the bin. This is the exciting thing about it. You look at nitrous, you look at anything around you, and you can suddenly find there's alternatives. There's new ways of managing pain. Not all of them with drugs. More and more in the ICU, we're recognizing that not everything's fixed by a tablet. So many of you in GP land would be so much more holistic. But everyone you see that looks vaguely distressed gets endone. And it's like,
right. Endone is a bit of a bugbear in general practice, I have to say. It's a problem for us. But, it's what you were alluding to right at the beginning, that so much is about our habit, about how we're used to doing things. And this is the way it's always been done. So we'll keep doing it that way. And, questioning it, and saying, well, maybe there are equally clinically effective ways where we're practicing good patient care and, looking after our planet at the same time, which is the fundamental thing we do need to do to practice good patient care.
Yeah.
Isn't it?
But
all
if
right,
we
look.
away without nitrous, we can sure as hell do it in cylinders. You know,
Yeah.
that's the thing. We can
Yeah.
start doing that straight away.
Great. All right. Well, look, I've posted again the link for the evaluation form. I'm sorry that the first one didn't work, to the people who've alluded me to that. But Roger, so I will email it as a link as well to the list today. But Roger, look, thank you very much for taking the time to come along and talk to us this evening. It's been a really valuable webinar, really enjoyable. I just think what Coda's doing is, it's a great thing. I'm sure lots of us are going to want to get some smuggle points. I think we've got a long way to go before we're smug supremo up there. But, every journey starts with a step. Let's keep going. Let's have a go. And, I think everybody's got a lot out of it. And I'm sure we'd all be clapping if we could, but it's an app, so we can't quite do it. But I'll clap. All right. Thank you, everybody, for coming along. And we'll see you at the next one. Do you want to just shout out to your conference, Roger?
Oh, yeah. Particularly anyone who's in Melbourne, 11th to the 14th of September. Huge amount of stuff there. We've got a GP focused workshop on chronic pain. We've got all sorts of pediatrics and other medicine, of course, because it's still a medical event. But there's a sustainable healthcare workshop. There's an equity workshop on the Sunday at the Edge Theatre, which is amazing, on gender inequity, with some really, really fabulous people. So there's a whole lot of stuff. I think probably if those of you can only be around on a Sunday or whatever because of your practices, the equity workshop will probably open up to just day registrations in another couple of weeks. So keep an eye out for that.
Fabulous, Roger. And obviously you'll have all just gone to IDEA 2022 Time to Act, which is in Melbourne on September 2 to 4 as well. All right. I will send that email with the link to everybody. All right. Thank you, everybody. Good night.
Night. Oh, we're still here.
Yeah, I'm just saying thanks again, Roger, now that most people have gone.
I just the question.
That was great. Thank you so much. You've obviously presented so many times. It's really great.
That's all right. Hopefully felt the passion.
Yeah. And, what great work you guys are doing. I just think I just love the idea that you started as this. I remember life in the fast lane when I was training. It really helped me a lot. And just the way that it's organically grown to, where you are now through engagement with people is just really fabulous. So good on you.
Perfect. All right. No worries. Thanks, Kate. Good luck.
Bye-bye. Bye-bye.